I will be presenting the preliminary results of a study investigating MR-guided HIFU for the treatment of appendicular osteosarcoma in dogs. I am a board-certified veterinary surgeon and professor at the Ontario Veterinary College at the University of Guelph. And this study is a collaboration with the Polson Centre for Image-Guided Innovation and Therapeutic Intervention at Toronto's Hospital for Sick Children. Osteosarcoma is the most common primary bone tumor in dogs and children, making dogs an interesting naturally occurring bone tumor model for osteosarcoma research. Canine osteosarcoma has a bimodal age distribution, but most commonly affects older, large, and giant breed dogs. It is an invasive and aggressive cancer that destroys bone locally and has a high rate of metastasis, which occurs most commonly within the lungs. While less than 15% of dogs have evidence of metastasis at the time of diagnosis, the majority of patients will develop metastasis within 1 year despite amputation of the primary tumor, which suggests the presence of micrometastases at the time of diagnosis. In dogs, standard of care therapy is amputation or limb sparing for control of the local tumor and pain, followed by chemotherapy to control metastatic disease. When amputation is not an option, palliation of pain is usually provided through medical pain management and in some cases through palliative intent radiation therapy. Prognosis for medical management is on average 2 months and for radiation on average 6 months, with animals being euthanized due to progression of pain. Even when aggressive standard of care treatment is sought, median survival times of 1 year have been reported, with only 20% of patients alive at 2 years. Since not all clients are willing to amputate and undergo chemotherapy, there is a need for alternative palliative treatment options in dogs. We are currently enrolling patients in a clinical trial that is aiming to determine if MR-guided HIFU can successfully ablate canine appendicular osteosarcoma lesions, if MR-guided HIFU can successfully palliate pain in dogs that do not undergo subsequent amputation, and to describe complications related to MR-guided HIFU treatment of these lesions. If possible, we also aim to assess the potential immune effect of HIFU on metastasis. Dogs with confirmed appendicular osteosarcoma where owners decline standard of care amputation and chemotherapy are eligible for this study. Dogs with metastasis and those that underwent radiation are excluded. Patient 1 was a 9-year-old Labradoodle with a distal radius osteosarcoma that was not suitable for amputation due to orthopedic conditions affecting his other limbs. Prior to HIFU, the dog developed a grade 4 out of 6 lameness that became unresponsive to aggressive medical management. Under general anesthesia, 3D T1 and T2 weighted MRI scans were required on a Philips Achieva 3T scanner for treatment planning. The patient was transferred to the HIFU table. Cooled and degassed gel served as the coupling medium to ensure appropriate acoustic propagation of ultrasound energy, ensuring there were no gas bubbles between the skin and the gel pad, as seen in the image on the left. We performed 13 HIFU sonications using 4mm treatment cells with power ranging from 30 to 50 watts for 20 seconds each, using the Profound Sonaleave V1 system with 5 minutes of cooling between sonications. Given the large lesion size and location, only a portion of the tumor gained contact with the gel pad, which limited our treatment window. Near real-time thermometry confirmed adequate ablation temperatures within the bone lesion without concern for overheating at the skin in the near field. Maximum temperatures reached for each sonication were all above 55 degrees Celsius, but did not go above 80 degrees Celsius. There were no skin burns detectable upon examination post-treatment or at follow-up. The following morning, the patient's lameness was much worse, as seen here on the left. He was barely able to bear any weight on his limb, but this improved and completely resolved over the following 96 hours. So we then see him 3 days post HIFU, and then running in the beaches 5 days post-treatment. This radiographic image shows evidence of the tumor regression in the treated region 15 days post-treatment, but also illustrates the limitations of our treatment window to the area that had good contact with the gel pad. The dog remained free of lameness for approximately 100 days, at which time he began to once again favor the limb. The owners reported that a divot was still present in the previously treated region. This is shown with the white arrow, and that the tumor was growing above and below this, so proximally and distal to the HIFU treated area. We confirmed there were no lung metastases and, with owner consent, performed a second HIFU treatment. This time, the team created a gel pad with an oval void to allow better contact and a larger possible treatment area. We completed 40 HIFU sonications using the previously described parameters. Treatments were rastered, and we reduced wait times between sonications to 2 to 3 minutes in an effort to treat as large a tumor area as possible in an acceptable anesthetic period. Analysis of the thermometry maps raised some concern for off-target heating in the far and near field, as seen in the top right and lower left panels on this slide, where temperatures greater than 56 degrees Celsius were sustained for a few seconds close to the skin. This off-target heating was attributed to more mineralized regions within the tumor. Immediately post-treatment, 2 very small skin regions, each measuring 1 to 2 millimeters in diameter and circled here in white, were suspicious for burn. These coalesced, and in the following day formed a split thickness burn that healed under a thin eschar without complication. Of greater concern was an unexpected burn that began to develop 2 to 3 days post-HIFU on the medial aspect of the treated region. This lesion gradually progressed to a full thickness burn, which took about 30 days to heal by second intention. Post-HIFU, the patient was immediately lameness-free and remained limb-free despite the burn for an additional 72 days following the second HIFU treatment. At this time, the patient developed an acute swelling and lameness in the right hind limb that was consistent with bacterial cellulitis and was considered to be unrelated to the osteosarcoma lesion in the front limb. Radiographs and joint taps were unremarkable. The owner declined surgical debridement, and since the swelling progressed with antibiotic therapy alone, they elected euthanasia. Postmortem histopathologic examination confirmed a chondroblastic osteosarcoma of the right distal radius with marked regionally extensive fibrosis, osteolysis, and reactive bone that were all assumed to be the result of HIFU treatment and histologically resembled what is seen following radiation therapy. Severe necrotizing fasciitis and cellulitis of the right hind limb was also confirmed with no identifiable cause, though Streptococcus canis was grown from this purulent lesion. There were no gross or microscopic evidence of metastases in any of the organs at postmortem. Case enrollment continues for this study, with one patient having undergone 2 HIFU treatments, which resolved the non-weight-bearing lameness, and another scheduled for treatment in the upcoming weeks. With only one case that has completed the study thus far, we cannot make any conclusions regarding our hypotheses, but our preliminary results in 2 dogs suggest that HIFU can ablate canine osteosarcoma lesions and can provide palliation of pain in dogs. It is unknown if it may play a role in suppressing metastatic disease and if curative intent treatment is feasible in our patients. It is likely that patient selection will affect outcomes, given tumor size and location may affect the ability to treat the lesion, and also the presence of soft tissue versus mineralized bone may actually affect the risk for burn complications. I would like to acknowledge Pet Trust for funding this study and the wonderful group of collaborators that I work with at Sick Kids, their sponsors, and of course, our patients and their families. Thank you.